Hadassah, and Dr. Alan Elad is an even younger cardiologist in our institution. He will present the case and discuss it with Dr. Elad.
Thank you very much, ladies and gentlemen. I will present a case of an oncological patient with chest pain. It's a 70-year-old man, which he was rushed to the emergency room with chest pain and signs of pulmonary congestion. His past history is relevant for non-ST elevation MI in 2005. He underwent coronary angiography, which showed triple vessel disease. And on the same admission, he underwent coronary bypass surgery, including a graft of Lima to left anterior descending artery, a saphenous vein graft to the obtuse marginal, and another saphenous vein graft to the posterior descending artery. 2011, he was hospitalized for urinary obstruction and hematuria. He was diagnosed with benign prostatic hyperplasia and was pretty much lost to follow-up. Between the years 2016 and 17, this year, he had an unintentional weight loss of 40 kilograms. Unfortunately, he didn't go for any checkups for this. 2016, he developed normocytic anemia, hemoglobin around 10 grams per deciliter, and again, no other diagnosis, no other workup was done. His risk factors are heavy smoking, diabetes type 2, and hypertension. In 2017, he was hospitalized in the internal medicine department for severe back pain and constipation. Total body CT showed diffuse lymphadenopathy, lung nodules, osculosclerotic lesions, and the liver lesion. His PSA was above 3,000. And of course, he underwent a prostatic biopsy, which showed adenocarcinoma with Gleason score of 8. This is his regular medication. His current hospitalization, as I said, he was admitted to the ER with shortness of breath and chest pain. On examination, he appeared pale, dyspneic, tachypneic. His pulse was 120 beats per minute. His blood pressure was 140 over 60 millimeter mercury, and he had a saturation of 88% on room air. His ECG showed ST depression on the lateral wall, and his lab was positive for elevated troponin levels, CPK, and a low platelet count. This is his example from his ECG, which shows ST depression V5, V6, good sensitive for lateral wall. During his admission, an echocardiographic exam was done, which showed moderate LV dysfunction and moderate MR. I would like to pause now and ask the audience whether or not to proceed to cath or coronary angiography, invasive procedure.
Well, we need two volunteers. One would say yes, one would say no, and then explain why. Danny?
You're my boss, Tom.
What would you do?
What kind of treatment do you see for the prostate?
Excellent. Good question. Sorry. Previous. Of course, he received dual antiplatelet therapy. Dual antiplatelet therapy, and for the prostate. No, we're not there. We're not there yet. We're not there yet. We're not there. No treatment. No. He was diagnosed. No treatment.
Okay. And during the same time, so he didn't have any time to begin. That's the patient that we have. Now he came with pulmonary edema and
with liver and bone and lung after.
Exactly.
I mean, also cardiac.
Maybe I'll join you. So it's one of the typical patients that comes in with, almost complete workup, and he has the tumor. We don't know the treatment yet, and he's coming to the cardiology department in pulmonary edema, and the question is what to do. So we started initial management, but the question is, should we be aggressive and take him to the cath lab, like we would have done with the regular patient that comes in with pulmonary edema and ST depression and chest pain, or due to the fact that this is a patient with generalized metastasis and not treated, and we don't know what's going to be the treatment, should we be on the conservative part? Sorry? Why do we have to choose? Well, you know, if we're starting to go with catheterization, we oblige ourselves, as we'll show later, to maybe intervention. Maybe some of the intervention are going to influence the treatment that he's getting. By the same time, we delay the treatment for his main disease. So the question, should we be aggressive, or should we just give him regular treatment and start with his chemotherapy and be a little bit more, because the situation is not coming with the STEMI, with acute myocardial infarction, which in this case, we wouldn't have any question, we'll take him to the cath lab.
I should mention that prostate cancer is very almost sensitive disease. I mean, can you consider the patient or inactive, or give you immediately an agonist? I don't find any contraindication. The patient in the beginning presents very aggressive. It's not typical for liver metabolism. The classic is in one metabolism. I mean, the patient should give the best treatment in parallel with or monotherapy.
The question is, what's the best treatment? That's exactly the question. And the question for us as cardiologists that saw him in the morning, how aggressive should we be? Because, you know, we can be very aggressive, go to the cath lab, try to open all the arteries, send him to surgery, etc., etc. Definitely, we're going to delay the treatment that he might get for his cancer, because he cannot get. Well, it's very difficult to do ocheectomy and cabbage at the same time.
May I comment? I'm on the conservative side. I'm the enemy of the intervention.
Okay, very good. So what would you recommend?
But this person, you cannot manage him. This is a patient with venous grafts, with unstable coronary syndrome, with ST changes, and with troponin. So unless there is a compelling contraindication like bleeding diathesis or 30,000 thrombocytes, then you should at least see what's going on in these grafts and this coronary. That does not oblige you to be an automatic, automatic, to do whatever necessary.
Automatic pilot.
You do the diagnostic and then you think. And if there is a critical lesion in a major vein graft, which you should open, because otherwise the patient is going to undergo a major infarction, then so you will delay surgery maybe for 1 or 2 months because of the antiplatelet therapy, dual antiplatelet therapy. But if there is no surgery involved, you can do whatever you want, 1 or 2 weeks after.
Okay. So you as a conservative cardiologist believe that he should undergo interventional workup?
I believe so. If you consider an alternative diagnosis causing chest pain, then maybe performing a chest CT beforehand, if it was not done before. But again, I assume that all the workup was done.
Well, I definitely agree with you, and this is part of the discussion we had in the morning, and I wanted to bring the discussion that we had during our morning rounds and morning meeting, because usually, as I mentioned, if it would have been a regular patient, we'll take him to the cath lab. Here, you have some question which, first of all, we don't know what's the treatment, how urgent is the treatment, how dangerous is to give him antiplatelets, heparin, all those in a patient who has metastasis, maybe bone metastasis, maybe liver metastasis. So the combination of those problems in the morning is the problem, but as you mentioned, taking the situation that the patient came in the morning with almost pulmonary edema and the diffuse changes in the ECG, we decided to go ahead and catheterize him, but I just want to mention that it's not, like you said, automatic pilot. You have to be very careful and take all the pros and cons together, and then tell the people that are going to do the catheterization that while they're doing the diagnostic angiogram, they should be careful about the second stage, how to approach and how invasive to be, because if you start treatment, anticoagulation treatment, it might be very important for the future of the patient if it can undergo some other operation. So maybe let's continue with the patient.
Okay, as we raised the debate, the patient went to the cath lab 48 hours after his admission. And on coronary angiography, as we can see, the white arrow pointing towards the area of the LA left anterior descending artery, his left main and circumflex arteries are all diseased and chronically occluded, of course. His right coronary artery was also totally chronically occluded. His Lima graft, left internal mammary to LAD graft, was patent and open with a nice flow, and as you can see on the bottom, a retrograde flow to the PDA artery. This is just a close-up of the same picture. His venous graft to the PDA was totally occluded, and he had another venous graft, as I mentioned before, to the obtuse marginal, which showed two critical narrowings towards approaching the anastomosis part. At this part, again, I would stop and ask maybe the audience, should we proceed to coronary intervention?
Yes, why can't?
Okay, so...
Well, we wanted the oncologist to see that sometimes we have also dilemmas. It's not that simple in cardiology. What I want you as an oncologist to know that we in cardiologists understand nothing about it. So for us, prostate cancer and lung cancer is on bowel cancer is the same. We are dealing with a patient and with diffuse metastasis in the morning, and then what do we do? And some of my colleagues said, go and open it because this is the typical, what we have a reflex that is called oculostenotic reflex. We saw a narrowing and we open it. Not always we are right.
Still there is a difference in the prognosis between prostate and lung or cancer. That takes into account.
I agree with you. So let's play the game. And this is a lung cancer. Would you, because for us, the question is generic. So,
you must remember that for almost each metastatic cancer where we see patient for the first time, the median survival would be, let's take pancreatic cancer, now it's 11 months, lung cancer can be even 2 years with new immunotherapy. It's a very long time. Now another question is how fast the tumor grows, and I'm talking only about solid tumors, not about hematological ones. The doubling time is usually about 3, 4, 6 months. So I suppose you can do that within 3 months or so. So finish the cut within 3 months, then we will confuse. So we have enough time to work with the patient. On the other hand, if it does because of the acute MI within 48, 72 hours, then we have nothing to do. So kind of a generic answer. We have enough time to do that in most of our patients.
that's very good. So at least now we are relaxed as cardiologists. The problem that we have, and maybe we should bring all the cardiologists to be more relaxed, because we feel that the patient needs urgent intervention. I don't on the oncology part, because he came with severe bone pain and everything. So the feeling was that he needs some very quick answer, and it can be some other things. And now I'm going to the cardiology thing. This lesion, and again, if we can go back. It's not a tight lesion, which means it's supplying only a small part of the heart. It's not something which is going to determine his all prognosis. And I can tell you that probably if the patient would have been with hemoglobin of 8 and with pain and anything, this would have been a small issue in him. The entire issue was due to his general condition plus the ischemia. So the ischemia was on top of it, and I can assure you that if we would have treated all the other things related to this oncology, this is not a major issue. So the question for us was, and as we discussed previously, we told the interventional cardiologist, don't rush, catheterize, and then let's think. Because is it a critical lesion? Is it something that is going to endanger the patient? Or is it some narrowing that maybe the patient is living with this lesion for quite a long time? Like you said, the doubling time, it's the occlusion time in our case. And because of his general condition, this became very prominent in this patient. So the answer whether to go ahead or not is not quite clear, but again, because we are cardiologists, you'll see what we decided to do. But what we wanted to aware ourselves is that we don't always have to open everything that is occluded, especially in such a case. And if you come to us and tell us, listen, in this patient, let's say it's diffuse lymphoma or whatever, and Professor Ben Yehuda tells us that he needs urgent treatment, we can survive with such a lesion also. It's not a life-threatening lesion. So, and the issue here is not whether I'm right or wrong. The issue here is just to bring the debates, issues that we have to consider before we're advancing with such cases.
So I'm sorry to disappoint you, but we decided, of course, to intervene. And after inflating a balloon in that lesion, we put a stent, of course, and the end result was excellent, as are all our interventions.
Not all, most.
Most. And surprisingly, 24 hours after the procedure, the patient developed massive hematuria and his hemoglobin dropped to 7. And now we're in a dilemma. So what do we do? Do we stop his dual antiplatelets? Do we reverse? Do we send them to an urgent urological intervention, which of course the urologist would love to do? Sorry, what was it? Where was the bleeding? Hematuria. Where did it originate from? Well, we didn't, yeah. If it's hematuria, this is the most logical place, I guess, for him to bleed from.
So again, we wanted to show you that things are not that easy because we are getting in those patients, which we are doing the procedure, very intense anticoagulation. In this patient, we had only Clexane and dual antiplatelet, but very aggressive antiplatelet. In other, we have to give anticoagulants, which makes the equation even much more problematic. And in some cases, when we put the drug-eluting stents, because of the drug-eluting stents, we need to continue the treatment for a longer period of time. But since Professor Gilon is showing me the watch, we'll continue a little bit more quickly. So basically, we didn't know what to do, like all of us. So we decided first to give him the blood. Due to the fact that we were already obliged with the stent, and we know that if we stop the antiplatelet therapy, the patient has a higher likelihood of stent thrombosis, we decided to continue. He was transferred to urology, which is good for us because we told them that we finished our treatment, and he started this thing. And luckily enough for this patient, the patient actually stopped bleeding, and the rest of the course was almost uneventful. Yes, we are at the 8th floor, they are at the 3rd floor, so exactly. So the whole issue of this simple case was to show us that we face a lot of dilemmas, part of it because we do not know entirely all the entire natural history of the disease, the treatment. So this is a need for us, and that's what's happening in our hospital, where we are trying to work more and more closer with the oncologists because we see more and more cases on the one hand of cancer, we see more and more cases, on the other hand, of ischemic heart disease. So from our side, we have to take into consideration what are the treatment, and especially the interventional treatment with ACS, PCI, dual antiplatelet, etc. And like you mentioned, we have to take also into consideration what is the disease, chemotherapy, and the prognosis, and the differences between lung cancer, pancreatic cancer, and prostate cancer. And at least I learned that even the aggressive doubling time, we still have some time for the stents. So thank you for that.
Thank you very much for both speakers.